Act came into commencement on the 1st of April. It's really important in this year that we really continue to share that learning, as we recognise that the boards are still in different stages of their implementation of all the requirements of the Act. So we hope today will provide a real platform for us to share with you some of our learning, as we are, in a similar position to yourself. We're still improving our systems and processes for monitoring the Health and Care Staffing Act, and also for our tool development. So very much continuing to evolve, and we suspect that will continue over the coming years. So we really want to gather those insights, share that knowledge and experience that you've had and we've had, and hopefully turn that knowledge into action, and you take away something from today that will improve your systems and processes in your own boards going forward. So very much part of our learning system as part of that quality management approach. So hopefully with the breakouts you'll be able to engage. Hopefully at the end of today you'll all come away with at least one nugget of knowledge that will improve practice back in the boards. We are really aware, and having been out in the boards in the last couple of weeks, just how challenging healthcare staffing is right now. And I think we really hope that the Health and Care Staffing Act is an enabler to improve health and care staffing, but absolutely cognizant of the current challenges in terms of workforce availability and that kind of ongoing legacy of the COVID-19 pandemic. But many parts of the Health and Care Staffing Act are about strengthening that workforce planning, strengthening those systems and processes for managing real-time staffing risks and challenges, which is absolutely necessary right now, considering what I've just mentioned. So hopefully that is, and we're looking to see in the breakouts what impact some of that is having in your boards, so that we can gather that insights and share, as I say, those good practices and improvements in how healthcare staffing is being managed, but absolutely recognise those fiscal challenges and the implementation of the new Agenda for Change terms and conditions, which absolutely is going to support our staff well-being, which is a requirement of that. But as we navigate through that, it is just realising the impact in terms of that increased staffing that we are needing within the board. So it'd be good to hopefully continue this sharing at future events as well. So in your evaluation, if you can give us any insights on what you'd like to have for topics for any future events, that would be great. So without further ado, I'm going to hand over to Lisa. Lisa is one of our senior programme advisors within the board, within Healthcare Improvement Scotland, and she's going to be sharing with you some of that learning around real-time staffing implementation. So thanks very much, Lisa, and over to you.
Thank you, Caroline. Good morning, everyone, and it's lovely to see you, albeit a bit virtually behind your little icons, so thank you. Kim, would you mind just moving on the slide, please? Thank you very much. So for me this morning, I'm going to take you through our real-time staffing and give you some alignment to the legislation of real-time staffing. So the aims within this presentation are outlining the key links of the real-time staffing to the Health and Care Staffing Scotland Act. I'm sure that this will be a bit of a revision for many of you here today, but for those that are perhaps coming a little bit newer to this, hopefully it will give you a good outline as to the processes and the resources available and the why. And then we will revisit the requirement regarding that staffing assessment and risk escalation, how that is relating to the Act, finishing with a reminder of the resources for everybody else and the direction of travel that we're on towards safe care. Thanks, Kim. So under the Act, health boards are legally required to be appropriately staffed, providing that safe, high quality care, and they aim to improve those outcomes for our service users, patients, staff, and wellbeing are all at the front and the fore of this Act. So the Act outlining several duties and guiding principles with that ability to assess that real-time staffing, and in particular that is 12IC, which is imposed by 12IA, that duty to ensure appropriate staffing at all times by staff who are qualified and competent from a range of professional disciplines as necessary in those numbers that are appropriate and such to provide high quality care, looking after the well-being and safety of our patients and support staff well-being. So that language will probably be feeling very familiar to you now, as it's part of our kind of daily language as we work through the duties. Thanks, Kim, for the next slide. And but that's the one. Thank you. So whilst all the duties in the Act are interlinked, and together with those guiding principles, they underpin the overarching general duty and main aim of the Act. But the three duties in the Act which specifically cover staffing risk, circled on this slide here in red, are 12IC, 12ID and 12IE. And the purpose of these duties relating to services evidencing their everyday staffing levels that are appropriate and that they can easily identify and dynamically respond when there are risks to service delivery related to staffing. The digitally enabled real-time staffing resources, these are hosted on TURAS, and there's Excel format for multidisciplinary, have been developed in conjunction with clinical experts from across NHS Scotland. They can be used by boards as part of their systems and processes and support boards to meet the requirements of the duties within the Act. So whilst workforce planning determines what the general staffing requirements or funded establishments look like within each clinical service area, in practice, the clinical activity, service demand, or patient acuity might change, just as the staff available to work within the service might change on a daily basis. So that need to determine what staffing is required to meet the changing daily needs of individual patients or the service using real-time staffing. So boards are required to have systems and processes in place to evidence that they are fulfilling their requirements in relation to these duties, but our resources, these are not mandated, and indeed some boards may have something else that they are using which aligns to the legislation. So you do need to know what is being used locally within your own area to comply with the duties. Thanks, Kim. So 12IC is the real-time staffing risk assessment, so specifically about assessing and recording the staffing required for the shift ahead and identifying the risks. Staffing risks which cannot be mitigated and should be escalated further. So this assessment should consider and report on the patient acuity, the levels of intervention where appropriate. It may not suit non-patient facing or unscheduled care services, so complexity of their workload would need to be considered differently. So although not actually required in terms of the Act, it does help to provide context, and we talk about how important context is against any of our numbers, and that can aid decision making locally. So recording that number and skill mix of available staff, who is working, who's on the shift, and the available staff for that shift ahead in the day on the day. We're professionally judging the staffing required. So against that, what is available to us on the day is what that professional judgment is telling us is required, who is needed for that shift to get through that planned, predicted workload. And then what risks are identified if there's not enough of the right staff, for example, insufficient skill mix, and how that might impact on service delivery. And then looking at mitigations, if any, can be taken ahead of any escalation. So perhaps contacting staff, bank staff, senior clinicians, or those supernumerary staff, senior or students coming off supernumerary management time, perhaps to take a clinical caseload, etc. Being able to record that as well. Thanks, Kim. So 12ID then, the escalation process itself. So the real-time staffing processes aim to provide a consistent means of recording the escalations and mitigations of any staffing risk. The resources available in TURAS allow for that, and they will also record if appropriate clinical advice has been sought out as part of an escalation response. As we've mentioned previously, there should be clear local processes in place for staff to follow, particularly around risk escalation, and it's important to know how to access these and how to use them. Staff should feel enabled and empowered and safe to use these processes, and they should feel confident to be able to raise a staffing concern and feel that that concern is being listened to, heard, and acted upon. They should know who to escalate to, and this should be someone with a lead responsibility and with a knowledge of the service area. So some examples of this are on this slide. Leaders should equally know what mitigating actions they can take and before they need to escalate any further. So there needs to be clear processes for feeding back to all those concerns that are raised and escalated, whether it's a person, the team raising the risk, and it's key to closing the loop on this so staff don't know who is left holding the risk and they don't feel that they are carrying that risk throughout their day-to-day, and also being that that risk is mitigated at a higher level. Thanks, Kim. So severe and recurrent risk in 12IE. So organisations again need to use their own systems of classification around what is severe and recurrent, as it's not defined within the Act. As a general definition, we would offer that this is where the same risks occur with no improvement, and that those areas where staffing is a challenge is becoming a severe risk to the health and patients of staff. As previously mentioned, real-time staffing assessment enables the recording of difficult decisions and also when there are staffing challenges. Real-time staffing resources record concerns, local context and mitigations, and these are invaluable to evidence and flag acute or sustained risks over time. Through reporting functions, real-time staffing provide the organisation with an operational and a strategic overview so that leaders can see what is happening in real time, as well as over time to identify that acute and sustained risk. And using this data in conjunction with reports from existing local systems and processes, such as DATEX, can help provide that wider and strategic view and inform decision making. Thanks, Kim. So what are those real-time staffing resources on TURAS then? So again, you may be using these in your day-to-day or even familiar with them, but they are they're not mandated within the Act, but it is a tool or a system that allows you to record that real-time staffing risk assessment. So again, you are required to do this by means of a process that you may have yourself or using these developed resources on TURAS. So whatever works, as long as it aligns with the legislation. These have been developed over the last 2 to 3 years in HIS, and we've developed this suite of digitally enabled TURAS real-time staffing resources, and you can see the list of these in this slide. They've been developed in conjunction with clinical experts from across NHS Scotland, so some of you who are here today may have been involved in those expert working groups. The current real-time staffing resources on TURAS cover critical care, HDU, mental health, inpatient and adult inpatient services in terms of nursing, midwifery, and both hospital and community-based maternity services in the TURAS processes, and they have been in use, like I say, for some time now. They do align with the legislation using these resources, and they also provide workload and workforce data intelligence to inform workforce planning and ensure appropriate staffing, which can be used as part of the common staffing method. Throughout 2024, you'll just see in the red note on the screen here that we have been retrofitting these TURAS resources with learning that we've taken from the generic real-time staffing resource and MDPJ. Thanks, Kim. And generic real-time staffing resource itself, as mentioned, it's not mandated to use these particular resources in the Act, but you must have another mechanism to do so. But this one provides a way of recording for those other professions who may not have the specialty-specific resource recording their real-time staffing. HSP were commissioned by Scottish Government to develop this real-time staffing resource to facilitate any staff group that is included within the Health and Care Staffing Scotland Act to undertake their real-time staffing assessment and capture the relevant mitigations and escalations that we've described to align with the legislation. A multi-professional expert working group in conjunction with colleagues from NES developed this generic resource. And despite the challenge navigating the needs of such a diverse group of professions to get an agreed resource, it is still recognised that it won't be everything to everybody that every profession would desire, but it does fulfil the legislative requirements to inform decision making. So as the name generic suggests, all professional groups and service areas can use this, whether that's in community, services such as mental health, physio, hospital at home, inpatient AHP services, ED and paediatric wards, outpatients labs, and the list does go on. So any service in principle should be able to use this resource. This year, we've been working to retrofit the additional features in this resource, like we've said, to those resources on the previous slide. And those additional features are in relation to escalation responses. So recording that feedback's been provided to all involved, recording whether appropriate clinical advice has been sought, and also if you agree or not with a decision that's been made and would seek a review, so there are facility within the resources to record this. The generic real-time staffing resource includes the function to record all that has been done as part of that escalation process. Updates to existing resources will mean that it's possible within those two. But please do be mindful and continue to be mindful that the TURAS application does not currently auto-inform anybody in terms of escalating that risk, and local processes should be followed for escalation. Thanks, Kim. So if you're maybe wondering why I'm highlighting the TURAS real-time staffing resources when there's a national implementation programme underway across Scotland for e-rostering and the SafeCare module, then you've already made the link. So we are on a road to SafeCare, and the resources developed are cognizant of this. Ideally, when you become a user of the SafeCare module, you should feel a sense of familiarity with the fields and the interaction. SafeCare meets the real-time staffing requirements of the legislation.
Sorry, Julie, I'm truly sorry. I'm in a meeting all day, and
a huge amount of discovery work, again with national expert working groups, early adopters from our brownfield sites of the former Allocate system, now RL Datex, e-rostering colleagues, Scottish Government, professional and policy advisors, HSP analysts, senior programme advisors have all been working really hard to align the functionality within SafeCare to the legislation to ensure that moving forward, professionals can have a once for Scotland consistent approach and mechanism to the real-time staffing assessment, recording and reporting. Thanks, Kim.
Now, so I've got the pleasure of passing over to Laurie Johnson. Laurie works as part of the national e-rostering implementation team within NSS and is the clinical lead. So I'm absolutely delighted to have Laurie along this morning. And just a wee reminder, Laurie, just to pop your camera on, and I will remember to switch mine off this time. So I'm going to hand over to Laurie. Are you there okay, Laurie?
I am. I'm here.
Brilliant.
I was secretly hoping they would have to compare me to my picture in the profile.
You're quite quiet, Laurie. Can I just check you've got your thing down? Perfect.
There you go.
Thank you.
I was drinking some coffee and having some breakfast. I think I'm going to pale in comparison compared to Lisa's presentation, but I'm going to give you a quick overview of some of the work we've done collaboratively with Scottish Government, Healthcare Improvement Scotland and health boards around the use of SafeCare and the Health and Care Staffing Act. And a plea to Lorna at NSS, because obviously I'm based at NSS. I'm available via email to contact me, and I'm happy to give you any demonstrations, because unfortunately we don't have time to do a proper demonstration this morning, but hopefully most of you will have seen SafeCare. But if you go on to the next slide, this is from the product developers themselves, a quick overview of what SafeCare is. So it's the ability to put in a patient census that will recalculate your care hours per patient day and give you a RAG status. It gives you that visibility of staffing in the form of a sunburst that you can see at the bottom left there. Allows nurse managers or managers in general to redeploy staff where they're needed, and hopefully help reduce agency and supplementary staffing demand in the long run. It also gives you that high level reporting, which will hopefully help you in your reporting your duties to the Act. Next slide, please. So just a call back to Lisa's slides in terms of those specific duties of the Act. So Safe Care allows a comparison of what you're planned, and this is like what we would call phase 1 of Safe Care. So if you don't have acuity multipliers, you can use it as a direct comparison to your planned staffing, and it will still give you a RAG status at that point. The next phase of that is to have an acuity multiplier, put in a census period, and be able to get a RAG status in comparison to that. We do also have the functionality to do what we call patient zero functionality, in which you can set the acuity multipliers to 0, so you're still being able to count how many patients, but not affect your RAG status, but in terms of that data for a retrospective analysis would still be useful. So the sunburst highlights that area, areas of risk, and professional judgment is the functionality where you can alter that RAG status according to clinical need, and it aids the decision makers in the redeployment of staff. And the professional judgment actions can capture those mitigations to staffing risks as well. In terms of escalation, it gives you that oversight with the sunburst and the professional judgment, but you're also able to raise red flags. So if you're continuing to hold a risk in that area, you've got another way of escalating that risk. And advice, mitigations and actions can all be recorded on the system. To address severe and recurring risks, obviously all of this can be pulled out into reports, so you can do some further analysis as well. Next slide, please. So progress so far, when we started looking at Safe Care, the default settings were very nurse and inpatient centric. So our focus was to bring a group together to re-examine those default settings and reconfigure it so that it applied to all staffing groups as much as possible, and aid in national reporting as well. So we got Scottish Government, Healthcare Improvement Scotland, NES, and key representation from health boards who had been using Safe Care. Some health boards using Safe Care for years and established processes around that. What we needed is for those processes to align more with the duties in the Act, and again to move away from being a nurse and patient focus. Once we'd done that configuration, agreed that configuration, we tested it at NHS Western Isles. We tested it there because they're a build and train model, which just means that the supplier built all of their rotas or rosters in one go, so that they could be live with multiple staffing groups at once, not just acute inpatient areas. And we then scheduled national refresh training so that we could align the duties of the Act to the Safe Care training at the same time. So that happened at the beginning of the year, and all of it was recorded and is now being housed in a dedicated Teams channel. Next slide, please. So where to find resources? This is the dedicated team channel, the Safe Care Alignment to Healthcare Staffing Act project. It houses all of the recordings from the refresh training, including key documents that the expert working group have produced as well. But we've also got the Knowledge Hub, which is the suppliers training academy. There's accreditation on there, but there's also just good training resources and videos on how to use the system. We've got the Knowledge Forum, which is a collaborative Teams channel and monthly event where all the e-rostering leads and representations from the boards come together to share learning. Your local e-rostering teams are obviously a very good source of information. And we're also planning some refresh training, mostly because we've had a lot of new functionality, which I'm going to speak about shortly. That's on Tuesday, the 19th of November from 2:30 to 4:30. I've asked if this link to the meeting can be shared in the chat so that hopefully you're more than welcome to come along and join that. We're hoping that some of the health boards who are represented on the expert working group will come along and show you in Safecare how they use the system and some of that new functionality as well. Next slide, please. These are the three main documents that you'll find in that Teams channel that will be helpful. The document that Lisa was alluding to, this first one, the Safecare guidance, it's taken every duty of the Act and compared it to the system. So that's every duty, not just the real-time staffing duties. How can Optima Safecare help you align with the duties of the Act? And it's gone through every single one. All three of these documents are currently being reviewed and updated, but these are the current formats of them. We're hoping as we go into a new phase of the programme post-November that we'll be able to share newer versions, but these ones are available to you just now. The next one is the Safecare Expert Working Group. Oh, sorry, back one slide, there we go. The Safecare Expert Working Group outputs, that is the national configuration. It's the recommended configuration nationally, so that if we run national reports, everybody's aligned, and it's aligned to the duties of the Act and the processes that go along with that. The last one, again, it's guidance on what kind of reports can you pull from Optima and Safecare, and how they might help you report on the duties of the Act. Next slide, please. So what's new? We've now got a senior review functionality, which means that as a senior decision maker in that area, you can apply a senior review to the census period and agree or disagree with what the outcomes of that is. There's the redeployment matrix. This gives the ability for staff to log preferences via their mobile app on loop, which we have some concerns about, to be honest with you. But more importantly, when you go in to redeploy a member of staff, it will give you statistics on how they've been redeployed recently. Are they constantly being redeployed? Is it, have they not been redeployed in the last 6 months, but their colleagues have been, and you can be a bit more fair in your redeployment. The red flag additional status. So red flags, you were always able to assign to somebody so that you could escalate a risk in the area. However, it always had to be somebody that was already on that roster. You could go into Optima and assign it, escalate it higher up, but we had issues around the back and forth between systems. So it was a key development ask from NHS Scotland that you would be able to assign the red flag to anybody in your organisation. You have to obviously create a template for the notification, and that would be sent by email. And that can continually then be reassigned as you escalate further, and feedback to the original red flag owner. There will be editable patient descriptors, and that just means that, and I think it's a key thing for everybody, the patient descriptors haven't been available as an information to say this is what this level means. And just allows the support and the categorization of the patients. Next slide, please. Coming soon, we've got in development, hopefully available by the end of November, but probably will impact you less. We've got a BAU dashboard to aid service management and ongoing implementations. But hopefully what will help in the future is the data hub integration into the CR platform to provide a much deeper analysis, and Nez is leading on that piece of work at the moment. In new versions, it will be also available on mobiles. The professional judgment downgrade partial mitigation will be one of the things added to that expert working group document. It isn't there at the moment, but it's to acknowledge that an area is still holding a risk. And also to be added is a decision review red flag, just to be able to log your disagreement with the previous outcome of a red flag or a professional judgment. Next slide, please. The staffing level tools, Healthcare Improvement Scotland is working with RL Datex, the supplier, to move staffing level tools into Safecare. No timeline specifically on that, but that is ongoing. There will also be bed occupancy views. This just means that you'll now be able to see your bed occupancy, and as an organisation, you can set the percentage to apply a RAG status locally as well. And they are looking into red flag unit applicability. So at the moment, part of the expert working group was that the red flags had to stay as high level and generic as possible to be able to apply to multiple staff groups, but we may be able to do something differently in the future. And Safecare metrics will hopefully be available in Roster Perform. RL Datex are working on that currently as well. All of these things are available in very specific versions of the software. So if it's something that you're really keen to have at your organisation, it will be a conversation with your e-rostering team to make sure that you've got the right version applicable. Next slide. I think that's me.
Thanks very much, Laurie. That was really great, and great to see those new developments in the system as well. So I'm going to pass over now to Ailey and Amir. Ailey and Amir are both from NES Technology and have been working in partnership with ourselves within Healthcare Improvement Scotland on the development of the real-time staffing resources on Turis. And I'm really delighted to have them here today and really appreciative of the work that they have done. So I'll hand over to yourself, Ailey and Amir, if you're there, if you want to pop your cameras on, and I'll switch mine off.
Hi, good morning, everybody. Thank you, Caroline. It's great to be here. My name is Amir. I'm the product manager that's been working on the real-time staffing resource over at NES, and I'm joined today with my colleague Ailey Manson, who's the delivery manager, again, been working on the real-time staffing resource. So I guess, yeah, there's been quite a bit covered already. Lisa's done an amazing job of kind of setting the scene. So we do have a couple of slides that might give a wee bit more information on what's already been touched on by Lisa. And again, Laurie's given a really good kind of what's next for people who are moving from real-time staffing into Safecare. So if we can just look at the next slide, Kim. So yeah, as we know, we've kind of covered this in quite a bit of depth already, the background and the ask of NTS. So we know about the Health and Care Staffing Scotland Act 2019, and that NES Technology Services, or NES as more commonly known, were brought on as the technology partners to develop an application that would allow us to record staffing levels in order to identify and mitigate risks. We can go on to the next slide, Kim. Thank you. So just a very high level overview of the journey to now. You can see there in December 2021, the critical care version of the real-time staffing resource went live amidst the COVID pandemic. You'll see shortly after that, well, in November 22 after that, we moved into the mental health version of the resource. And in that time between critical care going live and mental health, there was a lot of kind of revisiting and refining the resource to make sure that we were continually improving. Moving on from mental health, we went into adult inpatient. You can see in January 2023, then into maternity in February 2023, and then moving into HDU, which was kind of a subset of critical care. We were looking at how we could split them out and basically give that unique and individual resource to HDU. And then a lot of work has been going into the generic resource, which went live in February of this year. And now what we're working on just now is this national resource. So that's where predominantly a lot of the effort that's been going in just now with our health improvement colleagues, those of you at the health boards who are part of the expert working groups, and then ourselves here at NES. If we can move on to the next slide, thanks. And again. Perfect. So what's happened in the national resource as part of the generic build and then moving into this national resource is we've had to develop the concept of time. So the initial resources that you saw, critical care, mental health, adult inpatient, maternity, and HDU, they were developed with no concept of time. So there was no shift or census period, as it's called here, which we took on in terms of feedback as something that was needed to be added into the resource. So you can see on this slide here on the left-hand side, we have introduced the ability to record the period of time that you're creating an assessment for. So you've got the start date, end time, start date, start time, end date, end time on the left-hand side. And then another element that we brought to the national resource is this ability to record both patient acuity or patient interventions. And I've heard a bit of conversation today about being able to do that. So if you clicked yes to patient acuity, then there would be levels 1 through to 4 for patient acuity. And then if you wish to record patient interventions, then you would be able to do so by clicking yes there. As per the previous resources, you are still able to record bed numbers there, so bed availability and bed numbers is recorded as well. If we move on to the next slide. Another new functionality that's been brought to the national resource is the staffing levels section. So this gives to enter their staff type, start time, end time, and also record the actual and professional judgment. So you can see on the screenshot that we've put above there that under the staff type you'll have a drop down, and we're not only recording agenda for change band now. So historically with other resources we were recording bands 2 through to bands 8. But now with the new resource, we're not only covering agenda for change bands, but we also have medical, dental, and other staff types included in that drop-down menu. Then on the right-hand side of that, given that we're now introducing a census period, we also want to be able to identify a true reflection of when staff are available and in shift. So we've got the start time and end time for those bands. Or those staff types, and then on the right hand side you can also record your actual and professional judgment there. So that's been well received there. If we move on to the next slide, Kim. And there's been a lot of conversation on risks and mitigations that Lisa touched on in her section there, and you can see here the risks and mitigation section of the application for real-time staffing has been updated to include options that align to the safe care option. So health improvement colleagues have been working really hard to ensure that, because there's been quite a bit of discussion on the sort of systems fatigue moving from place to place. So there's been a bit of focus on trying to ensure that those who are using the real-time staffing resource and going to be moving on to safe care will be familiar with the terminologies and options that are available. So that's what we've brought into the national resource, or those options that would be the same as what are being used in safe care. Next slide, Kim. Another part that we've worked on is the escalation process. So prior to the national and generic resource that's been developed, we were using just a kind of escalation process that required the user, once they got to the escalation process, they would enter the name of the person in, and at that point the process was done. But what we've identified, or what we've had to develop, is in line with the legislative requirements, would be to be able to close that loop and record certain information that is required by that legislation. So you can see on the left hand side we've got the question now, did you seek appropriate clinical advice? You're then given the option to record the name of the person who gave you the advice and what advice was given. And then in the further escalation required part in the middle there, you can see that there has 2 new questions there that we've added into the national resource, which is, have you informed the initial escalator of the outcome? And have you mitigated or accepted the risk? So again, part of the legislation was closing the loop and ensuring that the escalation was dealt with and it was either mitigated or accepted. And you can see there on the right-hand side, we're just showing that similar to the other resources just now, the further escalation required, yes or no, who did you escalate it to, and any further information. So we're really trying to capture not just all the information that we need, but the outcomes that have come from the escalations as well. If we can move on, Kim. I'm now going to pass on to my colleague Ailey, who's going to just touch on the reporting element that we've brought into the national resource, if that's okay, Ailey.
Thanks, Amir. So the reporting on the TRS real-time staffing application is done in 2 parts. So you've got your operational reporting dashboard, and that's really looking at your here and now data. So it only looks at yesterday, today, and tomorrow on your reporting dashboard. And this is where you can see kind of a real overview, your count of assessments, where there are risks, what your staffing levels are, any escalations that are currently active and ongoing, but also have been closed off. As Amir mentioned, that kind of closing the loop, and also patients and interventions where appropriate. So Amir touched on that as well, the ability to gather that data. Moving on, Kim. And then data over time. So this allows users to see data over a much longer period of time. So you can look at 1 month periods, all the way up to 365 days, so a whole year. And this is really key when it comes to that duty of the Act. I think it was 12, i.e. the ability to record severe and recurrent risks. This is where you would be able to see that as a snapshot. And again, it's those kind of trends, recurring risks, and also a bit of that operational stuff. So count on assessments where escalations have been closed off, but it's all just about that kind of longer period of time. Next slide, Kim. Another massive improvement that we have brought in is the functionality for boards to manage their own users within the resource. So historically, it has always been done through the team at NTS, and for those on the call who've been involved in that process, it can be quite time consuming. There's filling out spreadsheets, submitting them to the service desk, waiting for them to be actioned, and then kind of feeding back the way. So we've worked really hard to build the functionality for boards to do this themselves. And we're really excited to be rolling that out this month. So this allows them to onboard, edit, deactivate, reactivate users. The only thing that UPM colleagues won't be able to do is onboard new structures. So if there are new teams or units to be added to the real-time staffing resource, that would still be through us at NES. But we're really excited about this functionality. We know that others are too. So really pleased to be rolling that out at long last. Next slide, please. So what's next? As touched on, we've got the rollout of UPM. Training starts next week. The national real-time staffing resource with all these improvements that Amir's walked us through is to go live in early 2025. We're really excited about that. And then, like I'd imagine a few other teams and areas, our funding isn't confirmed past March 2025. So we're not quite sure what the landscape looks like, but at the moment, we're working really, really hard to ready ourselves for any situation we find ourselves in. Next slide, please. Thank you. That was a whistle-stop tour of the TRS RTS application. Wonder if we have any questions.
Thanks, Ailey. Thanks, Amir. That was great. And even since the last time I saw it, what an improvement in terms of the functionality. The reporting is looking great, and to have that user access handed over to the boards will make such a difference. So massive well done to yourselves and for all the work you've done. So we're moving on then to our next speaker of the morning, and I've got the pleasure of introducing Kelly, one of our senior programme advisors, and she's going to give a wee bit of an update in terms of what we are seeing in relation to our monitoring role of the Health and Care Staffing Act. This is a new role for Healthcare Improvement Scotland that commenced on the 1st of April, where we have a requirement to provide assurance to Scottish ministers around boards' compliance with the Health and Care Staffing Act and all of the duties under that. So we have, as many of you are aware, been requesting the board's internal quarterly reports to provide us with a bit of a basis to inform that monitoring role and to triangulate that with some of the quantitative and other intelligence that we hold within Healthcare Improvement Scotland, but also to provide that opportunity to inform our board engagement calls and to be able to expand on that within the engagement calls and to try and avoid the necessity for us to ask for a lot of evidence from the boards and putting that undue pressure on the boards for supporting evidence on how they're meeting the requirements of the Health and Care Staffing Act. So at the moment, what we're doing is we're requesting those internal reports, having a good conversation through those engagement calls, and then if there's a requirement for any additional supporting evidence from the boards in relation to their compliance with the Act, then we can do so in a proportionate manner. So that's where we're at the moment. And Kelly's been amazing in this space around supporting the inspections that we undertake across the boards and also some of our other assurance work, and has been looking at these quarterly reports and sort of pulling out the themes that we're seeing from across NHS Scotland. So I'm going to hand over to Kelly to give some insights from that in relation to real-time staffing duties. Thank you, Kelly.
Thanks, Caroline. Yeah, good morning, everybody. And as Caroline said, I've been asked to provide a quick overview of the emerging themes from Q1 relating to the real-time staffing duties of the Act. I'm aware that we are sort of halfway through Q3, so there will be some progress around these from what I'm highlighting today, and it is great to hear via the chat box and discussions already today about what's going on in boards in relation to these real-time staffing duties. So as Caroline's described, we are analysing data and intelligence as part of his role and function. So we're going to look at the board's reported levels of assurance, success and challenges in terms of themes from Q1 and what this looks like when it's triangulated with other sources of data intelligence that's available to us. Next slide, please, Kim. Thank you. So we received a variety of different formats of internal quarterly reports from Q1, and I think we're looking at some of those later on in the agenda. Many of the reports contained the Scottish Government level of assurance RAG rating. Some didn't, which is absolutely fine. But to get a bit of a baseline general idea of where boards felt they were in terms of assurance, we did look at these RAG ratings, and 14 boards provided a RAG status relating to the real-time staffing duties. So you'll see from the slide that most boards do report being at least reasonably assured in terms of these three duties, and monitoring of severe and recurring risk is one of the duties where boards are most confident overall. So 90% of those that provided a RAG rating here are at least reasonably assured, and a third reported they are green or substantially assured in their systems and processes relating to duty 1 to IE. Next slide, please, Kim. Thank you. So we could see that boards are reporting using a variety of different national and local systems and processes to support the real-time staffing risk assessment and management. The majority of boards reported using huddles in conjunction with other processes, and huddles are reported to have good multi-professional engagement, and huddles also allow for access to immediate clinical advice and decision making, so a nod to another duty being covered there. And I think although there are there's reported multi-professional engagement relating to real-time staffing duties. No board as yet has confirmed that there is a completely consistent approach embedded across all professions and services, or that all professions and services have indeed got adequate processes in place, as Caroline touched on earlier. Most boards are reporting, however, that they have got established systems and processes, mainly within acute nursing services, for example, implementing safe care as well as using staff in huddles. And as we see safe care being implemented, so the 2RAS use will drop off. There are several reports of preferred escalation systems and processes, for example, via DATIX, via huddles. A few boards are using OPOL, and most boards confirm that they have got SOPs in place for clarity to support these systems. DATIX, Safe Care, 2RAS, etc. reported as allowing for analysis of data over time to monitor and manage severe and recurrent risk, as Laurie and Ailey touched on earlier there. And DATIX does seem to be the preferred option in terms of recording unmitigated risk, but this doesn't always allow for a timely response, and I do believe that DATIX is being phased out in the near future to be replaced with what's hoped to be a more efficient system. And staff and risk is reported to be a standing agenda item in various local risk oversight forums, and that includes looking at risk registers as well. Next slide, please. Thanks, Kim. In terms of challenges, many boards are reporting that they are finding challenges with having multiple systems and processes in place. Consistency and compliance is variable, and a lack of standardisation is also proven a bit difficult for some, and there's challenges around evidencing across all professional groups, particularly where local, more informal processes are being used currently. I think several boards mentioned informal escalation or mitigation discussions, for example, that happened over the phone, were often not captured. And where there's no immediate decisions made during huddles, for example, feedback loops and evidence and mitigating actions and decisions was identified as a challenge also. Several boards identified fiscal challenges as well as capacity to support implementation of new systems as a concern. So thinking about the time taken for training and onboarding, etc., where there's sustained clinical pressures. And some boards reported that there's a lack of available mitigation options as well in terms of staffing challenges, particularly for small services. Next slide, please. Thanks, Kim. In terms of what the evidence is telling us when we put together what boards are reporting with the other data intelligence available to us, we can see that sometimes there's a bit of a disconnect between what's being reported versus what's happening in practice. And boards, as you've seen, are generally reporting confidence in the real-time staffing systems and processes, but they are at varying stages of implementation of their preferred or interim solution, depending on the professional group and or service type. Processes are often clear in terms of acute nursing, for example, but it can often be unclear for other professions and services, as we touched on earlier. And boards are still developing processes in some cases, and they do need to be assured that these are effective in practice as well as meeting the requirements of the legislation. We're seeing through board internal reporting that where there are gaps or challenges or concerns identified, there are not always actions identified to address them. And this will be explored further via the board engagement calls, as Caroline described. Ongoing system pressures and staffing challenges are a national concern and absolutely impact on real-time staffing risk and the available mitigations to ensure safe and effective care and staff well-being. And where there are significant and ongoing pressures and challenges, there's a question around how quality, safety and staff well-being is being considered and protected. And we've seen some effective and efficient examples of real-time staffing processes in practice, for example, staffing discussions during huddles, and also some that show opportunities for improvement, for example, for a move away from a more roster demand focus to a more professional judgment focus, which will support meeting the guiding principles of the legislation as well as the staffing duties. And We're going to be looking at common staffing methods a bit later on as well, so how boards are using real-time staffing data and evidence as part of monitoring and managing real-time staffing risk, and as part of triangulation with other workforce quality and safety data to inform longer-term planning to support guiding principles and duties within the Act as a valuable and important processes for boards to be able to demonstrate. So that's my brief overview of the emergency teams from Q1. I'll hand back to Caroline.
Okay, I make that gone 1:15 now. So Lynn, welcome and thank you very much for starting off our afternoon slot and sharing some of the really good work that's going on within NHS borders, particularly around the reporting, which I know many of the boards have been at different stages of setting up their internal reporting governance and thinking about what those reports to their board looks like. And we've obviously been fortunate to see all of those reports come through to ourselves over the last sort of 6 months or so. So really good to hear some of that learning from your perspective within borders. So I'll pass over to yourself.
Okay, could I have the first slide, please? So I'm just giving an overview of NHS Borders experience on how we have dealt with reporting on the Act. So I'm talking about pre-implementation year and then this first year with our board reports. Next slide, please, thanks. So in the pre-implementation year, each board was asked to give quarterly reports back to Scottish Government, and there was a template on Excel provided by the Scottish Government for use. Now, within that template, each duty was highlighted with a number of subsections as well to be considered. And then ongoing from that, to look at an overview of the achievements and successes or risks and challenges that were identified by each board in terms of how they were managing to comply with the legislation and implement it. And finally, a path to green. So that was about the RAG status. How did we move from possibly not having any assurance or minimal assurance to that green where we were assured that we were able to meet the needs of the legislation? Sorry, Margaret's got her hand up. Do you need?
Mistake, apologies.
Okay, no problem. Next slide, please. So we asked for the clinical and professional leads each to complete the template initially because I'm a nurse by background, but obviously we needed to get information from pharmacists, psychologists, healthcare scientists, etc. So in the first instance, at the first report, I did send out the template that the Scottish Government had provided. And the feedback from the leads in terms of the use of the template was that it was much too large and unwieldy. They felt that the subsections were too repetitive with a language that wasn't easily interpreted. And I think, you know, a lot of us on the call have been living and breathing the legislation for the last 2 or 3 years. But for people in their day jobs, it's perhaps not as familiar. And so they were unsure what they were really being asked some of the time. And also the size of the document made it very time consuming and labour intensive to complete. Next slide, thanks. So that led to a number of ongoing challenges with that particular template. We got poor and or slow responses from some leaders in the organisation due to the time pressures that they were working under. Some leaders didn't actually really engage at all, partly because of time pressures and partly because of the actual document, I think. The information was difficult to show in an Excel document due to the massive size it became, because once you started to input data from all the different clinical specialties, the narrative was huge. And as you know, with an Excel spreadsheet, you're having to kind of flip back and forward between boxes to be able to read that narrative. And we did try various ways to make it better. We did try colour coordinating information according to different specialties. However, that solution wasn't really seen to be adequate either, because it wasn't working for the government and it wasn't particularly easy to implement either. Next slide. So the feedback from the Scottish Government initially was that all groups in scope of the Act were to be reported on, and they did want a degree of information and detail on each of the clinical groups. However, when we presented it in that spreadsheet, the feedback that NHS boarders got was that there was too much information and that made it difficult to analyse. So I think by that time it was for Q3, and they asked for more of an overview rather than the information presented in the way that we had done so in the Excel spreadsheet. Next slide, please. So what I did to look at this initially was a template was shared by my colleague Linda McLaughlin in Ayrshire and Arden, and we're all very thankful for that. And there was a number of questions in that to be posed to the clinical and professional leads. It was a much easier language to ease the interpretation and responses that we might get from the professional leads. However, I did tweak it slightly and added some extra questions that I felt were pertinent to our small board. We tried it in Q3 and we got much more effective responses from the professional leads. So I tweaked it further and have gone on to make the questions much more sort of open and inquiring, but still trying to use that easier language and make it easier to interpret what the professional leads are going to try and tell me. And so the responses were even more meaningful for the Q1 board report, which we submitted. Next slide, please. So we were told by HIS that we could use alternative templates for board reports. We didn't have to use the Scottish Government template. So I developed a Word template, for the quarterly report. I have based that on the SG information requirements, so I still within that present us a current status on what we are doing with each element and a RAG status, although it's for each duty rather than multiple individual elements. I still chart what the progress and successes have been and highlight those, but also identify what the challenges and ongoing risks are. And, not all of them affect every professional group, so it's much easier to highlight individual areas. And then a path to green of what further activities we need to undertake in order to reach that level of assurance that would be required for the government. This was agreed with the executive lead for use, and the feedback from the executive lead and from the board was positive as well as the feedback nationally from HIS when they received the Q1 report, and we've obviously submitted Q2 report. So that was much easier to read and interpret that. Next slide, please. So there has been learning from the report writing, and that will be ongoing. The first thing is that timing is crucial. If we request information too early from the professional leads, the request gets deprioritised because there's so much else going on in every board. But if we request the information too late, then it puts much more pressure on the leads for the time that it takes to provide that information. It does require regular contact with leads, and sometimes that'll feel like I'm nagging. And it's, emails, phone calls, Teams meetings and face-to-face meetings to try and support them and try and guide them as to what they are needing to provide information on. We need to have a process for escalation of concerns where we're not getting information back, and we need to ensure that all the clinical groups that are in scope are getting engaged. The reporting will have to become business as usual as the future progresses, so that needs to be considered as well when everybody's already under pressure and struggling with this, and how we're going to publish the reports next year to make it user friendly and public ready will need to be a further consideration. Next slide, thanks. And the successes today, I think certainly in the last quarter we've had a clear increase in the level and breadth of engagement from professional leads. The result of that is we get increased levels of detail, and that can lead to some concerns. It's a kind of dynamic process. We move forward in some areas and we sometimes fall back in other areas. So it's, as we get more detail, we realise what we need to do differently and, any gaps. I would say that we've had feedback from approximately 90% of the clinical staff that are in scope of the legislation. So there are a couple of pockets of staffing where we're struggling for that feedback, and that comes back to that escalation. However, it is a work in progress, and I do see benefits And, you know, I have used a Word document rather than Excel, but we will need to consider what we're doing going forward and how other boards are approaching as well. So part of that shared learning. That's my presentation. Thank you.
Amazing, thank you very much. I think we're going to have questions at the end of the three speakers, if I am correct, if I'm not. So hold fire, Lynn, if that's okay. But first of all, I'm going to pass over to Kevin within NHS Lothian to give us his overview of the reporting. So welcome, Kevin. Feel free to pop your camera on if you want.
Thank you, it's on now. Yeah, so good afternoon, my name's Kevin Dixon. I'm one of the Health and Care Staffing Leads for NHS Lothian. I'm going to give a presentation on some of the steps we've taken as part of our quarterly reporting compliance cycle at NHS Lothian. I'm part of the NHS Lothian's Health and Care Staffing team. It consists of Associate Director, Corporate Nursing Fiona Tynan, Health and Care Staffing Leads, Mags Cantley, and we have Margaret Russell, who's our Safe Care Clinical Lead. And we also have key stakeholders from multiple professions who work closely with us on a daily basis. My background is in recruitment and workforce planning, and within these roles I'm able to pick up some data analysis skills which I use in creating the board quarterly compliance report. You'll see from the process that we are learning, improving and refining quarter on quarter. However, I've split the process into 6 steps, which covers the process I went through for each of the first board approved compliance reports for quarter 1. Next slide, please. So step 1 involves our compliance and assurance audit. We used an audit to understand compliance across the organisation and use staff views on compliance to help construct the quarterly health and care staffing board report. This is essentially a questionnaire that was available online using JISC. So with the help of our professional leads, we created 62 free text or multiple choice questions. The audit also asks for your area and profession to understand area or profession specific gaps. Our professional leads need to produce targeted actions to increase compliance with the legislation. We tried to match the type of questions that we had in the audit, the type of questions that you have in the annual report. The thinking was that at the end of the financial year, we could use the audit results to help complete our return as a board. This step also involves creating a distribution list, and we asked each of the professional leads to provide us with a list of staff. This produced 22,961 words and 38 pages of free text. And so a challenge has always been about how do we act on that vast amount of information and we've received quarter on quarter. So services also found the questionnaire useful as an educational aid, and it was essential that we had that professional lead input to ensure that the questions made sense to all staff groups. Next slide, please. So as mentioned previously, we tried to align the questions in compliance audit to the annual report template. We also used the health and care staffing annual reporting template rating criteria. You can see our version at the top right-hand corner. So essentially, we took responding data from JISC in Excel form and combined this with professional views to create an annual report rating. The table in the middle right breaks down by profession, and you would have one of these for each of the duty within the legislation. We also gave an overall compliance by duty for all professions, and you would have one of these for each of the duty within the legislation. So we give that overall compliance by duty across all professions and use the chart to analyse some of the multiple choice questions. Excel pivots played a big part in the data analysis, and the ratings and the charts are all calculated using an average responses to the compliance audit. As you may have multiple questions per duty and multiple responses by profession. We also conducted a thematic analysis of the free text answers as we asked respondents for their successes and challenges around meeting the duties of the Act. This again mirrors the type of questions in the annual report to the Scottish Government. Next slide, please. So step 3 is actually creating the health and care staff and quarterly board compliance report. This stage involved a lot of input from our professional leads, and we had one lead. We have one lead from each of the professions, and we actually filtered down the PDF compliance audit results by profession and sent these out to each of the professional leads with the raw data. When they asked, we then asked the leads if they had any ongoing or planned work for their profession that had not been captured in the audit. as well as any successes or challenges that they would like to be included in the board compliance report. So we would combine this with a narrative provided by the respondents, and this would give us context and some background around the audit results. We provide the background text for each of the duties and for the guiding principles in the board compliance report. We also have a rating table for each of the duties as mentioned previously, with a red, amber, yellow and green rating broken down by profession. This in addition to the overall ratings per duty across all professions. And the success and challenges in the red, amber, yellow, green rating would help inform recommendations in the report. Next slide, please. So once we create that board compliance report, it's time to go on a governance and assurance journey. So you can see in the diagram that we start with audit, which feeds into our quarterly compliance report. And we hope to use this information to help complete the annual report when that time comes. The quarterly report then goes into our Health and Care Staff and Programme Board for review and approval. Then on to our Staff Governance Committee and our Lothian Partnership Forum, and then on to NHS Lothian's Board. We also have our meeting with the Scottish Government and Healthcare Improvement Scotland, where the quarterly compliance report is considered. So you can see that the quarterly report has a few stops in the way to and after the board, and one challenge is trying to get all the timings right. We've reviewed this process several times to think, how can we slim it down and how can we use the time between each board report more effectively? Next slide, please. And this brings us on to recommendations. Each of these groups and key stakeholders in the slide gives feedback and recommendations. Step 5 involves receiving feedback on the compliance report and the compliance and assurance audit. We can use these recommendations to make changes when the report is moving through the governance and assurance landscape, or there may be recommendations to improve the audit or the board report for the next quarter. And feedback often includes improvements to ensure appropriate assurance levels. Next slide, please. So step 6 is the final step, which is about responding to those recommendations from key stakeholders. There are ways in which we can improve the compliance report quarter on quarter. Some examples of improvements we've identified are including more areas of professions, for example, chaplains, reviewing distribution lists to increase engagement rates, further refining the compliance audits, so how do we reduce the data burden for services, introducing a digital review process to increase flexibility between submissions, profession-specific analysis, so where there are differences between and in between professions, capturing more staff views, how do we audit a larger proportion of staff, continue to raise awareness of the compliance report and the audit, focus on specific duties where we've identified gaps, and of course, as always, sharing best practice with all our good colleagues in workforce and Scottish Government and Healthcare Improvement Scotland. Last slide, please. So just to go through the kind of 6 steps that I mentioned, essentially you've got the compliance and assurance audit that goes online, and then we use that to do data analysis, and then we use that analysis to create the board quarterly report, and then that goes on that governance and assurance journey, and through that we get recommendations, and that leads to hopefully improvements in the quarterly report. Thank you.
Thanks very much,
Thanks.
Kevin. That's really robust and great to see that internal assurance systems. When we think about assurance, that board internal assurance, and then that kind of HIS external assurance, and interesting to see your kind of thematic approach as well around where you see gaps, and that's a similar approach that Healthcare Improvement Scotland have adopted within our framework too, although we haven't undertaken a thematic review yet because we're still sort of gaining that understanding of where boards are at with their compliance. I think, really helpful to see that alignment, so thank you. I'm sure there'll be some questions when we get to that stage, but before we do that, I now got the delight of passing over to Suzanne Ross and from NHS Tayside to share her experiences. Thanks. Can you hear us, Suzanne? You're not on mute. Are you there? Susan, are you there? Oh, I see you coming now. Brilliant. You gave me the panic there. I was going to have to fill a slot.
Carol here. Suzanne's just going to come out and go back in again and see if she can get her mic to work.
Oh, perfect.
But I'll start and Suzanne will jump in once she rejoins us. So Kim, if you can move on. First slide. So just set a little bit of context. So we were in very much in the same position as all the other health boards when we first looked at implementation and how on earth we were going to manage to align all the professions that were working across multiple directorates and operational groups, and how we were going to collate their compliance and where they were at with the legislation. So what we did was we identified a governance structure which became our reporting structure, and the two are absolutely interlinked and intertwined. And so we aligned everything along operational lines rather than professional lines. There's subgroups for each of the operational groups, and each operational group is responsible for reporting on all the professions within their areas of accountability and responsibility. The subgroups feed into the programme board. The programme board, and this will become clear, and Suzanne will talk about this in more detail, leads into the lead professionals. We then report up to Staff Governance Committee and ultimately to a NHS Tayside board. Suzanne, are you back with us?
Can you hear me?
Yes.
Yeah, fantastic. I'm back. Next slide, please. So, as you will all be aware, you know, in an organisation our size and as in all your trust, there is, you know, we need to have multiple layers of assurance for this legislation. So the first layer of assurance for us sits within the subgroups. So like Carol had said, we've been operational lines, and these are the 7 operational lines that report into our programme board. But what we'll discuss first is really how do the subgroups get assurance from their service that, you know, that they're meeting the duties within the legislation. Next slide, please. So this is the operational model. It allows us to ensure that, you know, that the legislated staff are all represented throughout the implementation period. It was a gradual process within each subgroup to make sure that every service had representation within the subgroup. The subgroups were, as I said, you know, initially developed to support that implementation, but they've now evolved into a real business as usual approach, and each of the services chooses how often they want to meet and how often and who sits within that subgroup. In terms of assurance into the subgroup, so from the services, initially we left it to the services to really decide how they got that assurance. It did become an issue because what we found is that services were then putting the Scottish Government template out to the services, and it was too much, it was too heavy, it was too legislative, and there was minimum response. So we supported the services and we developed our quality assurance reporting template, and I'll show you that shortly. And we've had really, really good feedback and engagement with it. The other level of assurance sort of at that subgroup level is the attendance. So ensuring that services are consistently represented at the subgroup, that there's good attendance, and a deputy will provide that cover if the main attendee isn't available. I do attend all the subgroups. I support them with doing deep dives into the duties within the legislation, to speak to them about what kind of evidence they could be looking to gather. I provide them with updates on where we're sitting with their educational resources. I provide them with updates on their compliance with the common staffing method. What we really try to do as well, though, is not focus too heavily just on nursing and midwifery within the subgroups, and really try and engage all the other professions within there. We update them on any Scottish Government and his updates. And what we also do is when we ask the subgroups to provide the reports to the programme board, I go back to the subgroups and give them that sort of feedback and where we expect to be progressing from there. So that's kind of our first layer of assurance, and that's services into subgroups. Next slide, please. So this is the assurance report. This is what the services have to complete and hand into their sort of subgroups quarterly. We tried to keep it as holistic as we could. We tried to move away from legislative language. We tried to really promote sort of shared learning right from this level. And what we're really looking for is where are your successes, and probably more importantly, where are your risks? So what you'll see here, I mean, you'll be able to see that, but it's really about, you know, looking at the Act as a whole. How are you embedding it? What are your risks? What are your barriers? You know, what mechanisms have you got in place? And then again, we're looking for examples. Next slide, please. So this is the second part of that same assurance document. What we do ask for is that RAG status as well, so that we can monitor any progression with compliance as the quarters go on. We found this report to be really successful. It doesn't feel quite as overwhelming for services, and we're getting the responses that we're hoping to get from it. Next slide, please. So this is our next level of assurance. So we have the programme board, as I'm sure most of you do, and each of the subgroups then feeds in to our programme board, and that is our level of assurance over the programme board. We have on the programme board, we have professional leads and operational leads, staff side, human resources, workforce, excellence in care, e-rostering, safe care, they all sit within it. So we'll have that sort of overarching approach to the legislation. Risk management and clinical governance also now are represented, and it just ensures that triangulation. We meet monthly, but it's 4 weekly actually that we meet, and initially it was to oversee the implementation, and we have now amended our terms of reference to so that we support the assurance of compliance. We have standing agendas on the standing items on the agenda. One of the really important ones is our e-rostering and safe care update, and that is where, you know, we are told about where our implementation levels are with safe care, where we're going with implementation, and what services we're looking at doing next. And that's a really important part for us. Myself and Carol give an update at the programme board, and that tends to be around, again, common staffing method compliance, educational resources, and also any updates that we've got from yourselves at HIS or Scottish Government. Excellence in care also report in, but what we also have at our programme board is each service provides us with what we call a flash report and talks to that and gives us an opportunity to share learning and have discussions, and I'll show you that shortly. But in terms of assurance into the programme board, we have decided within Tayside that we have asked the subgroups to use the Scottish Government template to report into us quarterly. We give an annual plan. Well, we did this year. We went out with an annual plan at the start. We gave dates that the expectation would be that the templates would be returned to us to allow us to collate and provide our updates up through our board. We found that this provided shared learning, and it was really sort of allowed us to gauge sort of the approach of some services against the others. We felt that it was really important to continue to use the quarterly report because we wanted that knowledge of what Scottish Government's expectation was around the legislation to filter down into the subgroups so that people had that real understanding and depth of knowledge going through, and it didn't just sit with us sort of as the experts. The other thing that we really monitor is attendance at the subgroup, and we try to ensure that if the main attendee isn't there, that we have a deputy, and that any sort of information is filtered out. As you'll all probably have as well, it sits on a Teams channel and we share as much information as we can through that. Next slide, please. So this is the flash report. So the expectation for us is that each service completes this flash report and has it into the programme board so that we can have a talk to it throughout the meeting, but we try not to spend too much time on it because it is available for everybody to see. But what we're really trying to capture here is areas of non-compliance, any high-risk areas, anything that we can support with. But this document in itself for us is an assurance document, and it's something that we use alongside the quarterly reports. We're looking for a brief overview of any sort of achievements and compliance. What have they got embedded? Again, shared learning, it couldn't be more important to us, and any issues or concerns for the programme board that we can support with, and any other issues. And we've found this has been really helpful on the programme board because what it's done is it's opened up that conversation amongst the services and everybody really sharing where they're sitting. Next slide, please. So this is what we have is called a compliance matrix. So from the quarterly reports that we receive from services, what we do is we pull, this is an example, by the way, this is not any of our actual RAG statuses, this is just one I pulled together. But for each duty that the services complete within the Scottish Government template, what we do is we pull out all the RAG statuses, so right from overall through to all the duties, and that is what we really have been using to feed up through our board and give us that sort of at a glance almost view of progression. It's an at a glance view of where our risks lie. But what I'll do is I'll go on to the next slide, please, and I'm going to let Carol, if that's okay, speak about this next level of reporting up.
So this hasn't transferred very well over onto the PowerPoint, so apologies for that. But if I take you down to the bottom of this, you can see that we've got our operational subgroups down at the bottom. So each of these subgroups report into the programme board. And the bit that's maybe missing on this flowchart is that Suzanne and her team sit in between the subgroups and the programme board. So we collate all the completed self-assessment returns from the subgroups and compile them up to the programme board into the quarterly reports. And all the subgroups complete the Scottish Government template in full, which is a bit pedantic, and we've taken that approach right from the beginning of implementation. But what that actually did is it first of all created all these subgroups so that they could work their way through this compliance with the Scottish Government report and all the subsections of it, and it really embedded knowledge and understanding out in the operational groups. So from the programme board, the quarterly report, any risks identified from that goes up on that left-hand line onto the strategic risk register for the board. The reporting line goes up to professional leads for the nurse director and medical director to sign off that quarterly report, and that also feeds into the executive leadership team, and they receive an update via our people and culture work stream the healthcare staffing legislation sits on the annual delivery plan, and it sits on the people and culture work stream, part of the annual delivery plan. We report direct quarterly report. It goes to our staff governance committee to provide assurance on the activity of the programme board and the board's compliance with the legislation. And from there, that then goes up to the board for report. And the staff governance committee provides the assurance that is fed all the way up from the operational lines into the health board. And then from these quarterly reports, we compile the annual report, and the annual report then goes to the chief executive and the executive lead for sign off. Back to you, Suzanne.
Sorry, I don't know if there's another. Is there another slide? Sorry, next slide. Yeah, so where are our next steps? We're waiting for this digitalised annual report to come from Scottish Government, and that's going to help to adapt our internal processes, because we want to continue to align with the Scottish Government templates and requests, just to keep that level of awareness amongst the subgroups. We're continuing to adapt our processes in conjunction with the services and leadership. We do want to reduce state of burden where possible. There's continued development of effective pathways to compliance, maintenance of educational resources and support programmes. What we've also done is create a template, I've not got that there, but to give people a sort of idea of what evidence they should be considering to gather in terms of reporting. We're trying to get to a whole system approach of the duties and just have that as a whole system, business as usual, and that's where we're aiming to go in the future. And I think that is us. Next slide. That is us. Thank you.
Us. Well, I think that's your last slide. Yes. So thank you, Suzanne. So we will certainly pass on now. We're going to hand over to Nancy Burns, who's our portfolio lead and has been absolutely instrumental in leading around HIS's new role and function on how we monitor board's compliance with the Health and Care Staffing Act. So she's going to give some insights from that and some of the board engagement calls that we've been undertaking. Some of those you've absolutely been part of, and I appreciate your input into those and feedback as we've gone. So Nancy, are you there?
Yes, can you hear me?
I can hear you. Can't see you yet, but I can hear you.
Oh, it should be on screen. It's maybe, I can see myself unfortunately on screen, so
well, I can see you now.
Great. Well, maybe not
lovely.
So great. So thank you for that introduction. Today I hope we can provide a kind of clearer understanding of HIS's role and function as cited in the legislation, and really how we've been delivering this role and what our learning has been so far. So next slide, please. So the purpose, again, of this presentation, as you can see, there's many duties that HIS have been cited as having, but I'm going to just focus on monitoring board compliance, power to require, and the function for duty for health boards to assist with staffing function. So as you know, we have our role and function to monitor the discharge by every health board, relevant special health boards and the agencies of their duties that are cited within the legislation. And that's part of HIS's kind of assurance function, if you like. But in addition to that, and this is a really important element, is we require to support that identification of good practice and I think I'm maybe on the wrong. No, I'm fine. Just ignore me. Identify really good practice, share learning, and provide that appropriate improvement support as necessary. But just to reiterate, I think there's some confusion with this statement, but it's actually NHS boards that have to provide assurance to Scottish ministers within their annual report of how they are discharging their duties. HIS have a role and function, and we have an obligation to provide an annual report and provide assurance and independent information to Scottish Minister of how boards have been discharging their duty, but also how we have been carrying out our role and function. And as Caroline alluded to in this morning's discussions, these annual reports provide kind of rich workforce information to Scottish ministers, all of which will provide that intelligence information and then Scottish governments will have to collate and evaluate this information and set out the risks and lay this before Parliament, and that's really to help understand the workforce requirements across Scotland, and all of which are really critical to support those guiding principles, that high quality, safe and effective care with positive patient outcomes, but also the impact on staff wellbeing, which I think we're all witnessing out in the system. Next slide, please. So on the screen is our 2 frameworks, and the purpose of the Healthcare Improvement Scotland and Scottish our healthcare staffing programme operational framework is to underpin the Healthcare Improvement Scotland and Scottish Government's operational framework, and the HIS and SG operational framework provides that high level operational planning. The framework has been written to provide clarity of how HIS will meet its legislative requirements of the legislation. The framework will set out, and it's available, it's published on the website, but it will clearly define our roles and responsibilities within the healthcare staffing programme and also the wider organisation in HIS meeting its legislative duties. It is a bit of our Bible, it's our working document to help steer and guide our team. But as there's been lots of iterations so far as we are building the plane and flying it, we'll review this document after 12 months. So next slide, please. So in line with both our operational frameworks, we apply a multifaceted intelligence-led approach to our work within HIS. We are really fortunate that the co-locations across HIS means that we can offer that shared learning, shared data, evidence, intelligence to support many of HIS's activities. The healthcare staffing programme, particularly our monitoring compliance team, have direct links with our quality assurance regulation directorate, and the healthcare staffing team, again the monitoring compliance team, support the safe delivery of care inspections, and we've also have a direct responsibility when staffing concerns are raised through responding to concerns. Other data, evidence and intelligence is sought, and we get that through adverse events, data measurement, business intelligence and other sharing intelligence via our safety networks. We work closely with SPSP and obviously EIC, which is one of my other work streams, and that's just to name a few. And we also seek other information through our board engagement calls and through the quarterly reports and agency reports, and we also can get information from Scottish Government, NMC, GMC, HCPC, all these acronyms, and our Mental Welfare Commission. But again, the list is not exhaustive, but all that information is really helpful and helps at triangulating this information with emerging themes that go across Scotland. Next slide, please. So what do we do to prepare for these board engagement calls? So to support our role and function, we made the decision to move to a board engagement call. So many people have said, well, why would you choose this as an option? And it was based upon our learning. So when we were doing the safe delivery of care inspections or responding to concerns, we often required to have virtual or face-to-face discussions with senior leaders or executives. And these meetings really offered those rich discussions and provided greater clarity, more so than you would ever get from data and evidence submissions. So therefore, we decided to adopt this approach. And I guess the harsh reality is the alternative would be that we would still require to review the quarterly reports, and we would require to use our powers to require information to ensure that we had all the supporting evidence to back up what's stated in the reports. This would have been labour intensive for all, and given the board pressures, I'm sure this method would not have been welcomed. However, important to reinforce that data and evidence may still be required from the boards. However, it will be essential and proportionate. It will be proportionate to allow HIS to carry out its role and function. As we talked earlier, we use that multifaceted data and evidence, and so we do a lot of preparation ahead of our calls, and I've just demonstrated that in a previous slide. Through our power to require information, we request your quarterly board submissions, and that's your own internal report that boards are required to submit as per their legislative duties to the governance groups. There has been, and I think we've seen that with the last three presenters, there's very many different versions of the internal quarterly reports. Some are really comprehensive and some are really limited in their information, and very few are using the annual Excel SG document. I think it's important to reiterate the DL letter stated that the quarterly SG report, the annual report, was not mandated for quarterly use, and it was only suggested as a recommendation, and that was to support ease of use for the annual submission. Our senior programme advisors who are aligned to the board will take time to review the content of the board quarterly report, analyse information, and an opportunity to review progress in previous reports to compare and contrast, as well as thinking about all the available intelligence. But as we move forward, we'll provide an opportunity really to kind of get underneath some of what is provided, so following some key lines of inquiry to understand compliance, but also, of course, to understand the areas of success. I think for our first call, there was some feedback, which we've made some improvements to, but our first calls were really around introductions, terms of reference, but mostly we didn't get a chance to go underneath and do a deeper dive, but we will require to do that as we move forward. So the SPAs are reaching out to the board workforce leads and developing some bespoke agendas for these meetings. The logistics is the governance complex, of course it is, both within NHS boards and within HIS, and I would say we were really naive to think the boards would all have established their quarterly reports and their governance meetings during the year of testing. However, that's not the case. That wasn't the case. So we had to set up some bespoke board engagement calls based around boards governance meetings so that we have the quarterly report ahead of the board engagement call. Next slide, please. Apologies for this slide in advance, but I just wanted this slide to really demonstrate the logistic complexity and periods of intensity that we have while supporting those 19 board engagement calls. It's just one tiny element of how we carry out our role and function. But most of the board engagement calls were focused on a 1 month period, which was really complex and labour intensive. And moving forward, we hope to get into a position where that is evenly distributed throughout the 3 month period, which will be very helpful. So of the 19 boards or 19 engagement calls, unfortunately, not all boards submitted their quarterly report ahead of the meeting, which really limited the conversation. And as you know, the boards have a duty to comply with supplying that information. Moving forward, we will need that information to support our legislative functions. But listen, we all appreciate we're all learning together in this new role and function. Next slide, please. So as I alluded to earlier, we have had some feedback on our board engagement calls, but just generally around our process. And I think one of the biggest one was a bit of the dynamic shift we had. So pre-commencement, partly we were there to support board's preparedness for the legislation. It was a really supported, positive, close working relationship, really valued between the SPAs and the board workforce leads. But following 1st of April, when the legislation commenced, HIS obviously had a new role and function. Again, that could have had potential to change the dynamic, and I think it did on occasions as well. So there was a significant gap between the 1st of April and our board engagement calls. So we have all reflected on that and potentially it caused some unhelpful distance, and there were concerns from both SPAs and the boards, but we've done quite a bit of reflection and learning on that. But as we move forward with the role and function, which is primarily, of course, to monitor how boards are discharging our duty, etc., our style will continue to be that of supportive and collaborative to support those working relationships. Our board engagement calls, prior to the board engagement calls, Scottish Government were testing out a proposed annual report, which of course formed part of the quarterly reports. So SG would provide some really useful, I think really valued formal feedback and pose some really useful questions to the boards, and provided that kind of development opportunity and insights how to where they could improve their compliance. This of course was during that period prior to commencement with legislation, and as we know, we've moved past that now, we're in commencement, therefore it wouldn't be it's not our role and function to provide that, but that caused a lot of disappointment within boards. So just again to reiterate, we're not there to provide assurance or formal feedback. So I think that was one of the greatest disappointments. Based upon our own reflections and that of the board's reflections, we really require to strengthen our terms of reference to be more explicit that our primary role is that monitoring function, share good practice and provide improvement support. Also, the board said, well, what's in it for me? If you're not providing feedback, what are you doing for us? And you know, we have to state the boards have a duty cited in the legislation to support with HIS's role and function, but also the board engagement calls, as explained earlier, doesn't negate completely, it reduces the need for that data and evidence, and there's such an appreciation of the pressures within the system. We also only provided verbal update and no written summary, but now we've agreed to a very short summary and just with a few key action points moving forward. And from a governance, again, we were really naive that the board engagement calls and the requested quarterly reports that everybody had their governance in place where these internal reports would have been submitted to. Of course, that everything was out of sync. But our reflection, I guess, from another reflection from the Healthcare Staffing Programme team is that we supported many of the boards during that testing year. However, perhaps we should have taken that opportunity to test out our own role and function, but isn't hindsight just a wonderful thing? And Kelly has presented this morning and Misha is just about to present, but there'll be some occasions when boards have a much higher level of confidence in their compliance with legislative duties than that is evidenced through inspections of responded concerns and other data and evidence intelligence. And as we strengthen our board engagement calls, we'll use the coaching conversation to seek greater clarity and understanding. But these calls are a really ideal opportunity to share good practice and provide boards that insight into what our findings have been, also for areas of celebration, but also reinforce that theory practice and provide the boards an opportunity for learning. So next slide, please. Learning, thank you. So we've had lots of learning. 5 boards did not submit the quarterly report, but moving forward, we need to strengthen that as part of the duties. And we truly understand the complexity within the governance structure. So we're working really hard to create sort of bespoke alignments. We talked about the terms of reference and how we've strengthened that. And there's now been 2 quarter 2 board engagement calls and still awaiting feedback on the terms of reference. And as I stated earlier, the board quarterly reports will be board engagement calls will be much more of a deeper dive, but it's a really great opportunity to hear about all the innovative and local approaches to how they're demonstrating how they're discharging their duties. And as previously highlighted, it's not for HIS to comment on or advise on boards how to operationalise their duties. We're only looking to see how they comply with the duties. Just another couple of slides and very briefly, we are carrying out a thematic review. This just provides a little bit of a screenshot of where boards are, and this is that level of assurance. Most, only 14 boards again reported reports, so that data is incomplete, but most people rate themselves primarily as yellow or green, and it'd be interesting to compare progress with Q2. And just finally, the next steps. As I said, we're going to do a formal thematic review, which will also support a lot of reflections from ourselves, but also provide HIS with compiling a bit of an annual report and shared learning, and also support our governance process. We have a number of governance groups, and these are the business meeting and our internal advisory group, as well as our quality performance committee. We've had 2 cycles of IEG and business meeting, and again, we'll reflect on the learning and adaptations. The inspections, where we get a lot of our rich information, we'll be now extending out to mental health and maternity services, so moving from 10 to 12 a year to approximately 30, so a real additional workload for the monitoring board compliance team, but they are really helpful, information intelligence to support boards, but also demonstrate how they're complying with the duties and celebrate that success, as I've said. But of course, the caveat, these inspections are limited because they are generally buildings with walls. However, we have other opportunities to have insight into other clinical practices. We've changed our practice recently on responding to concerns. What we will be doing in our board engagement calls is bringing some of those responding to concerns and their inspections as part of an action plan, and seeing how you are progressing with those as a follow-up. And we're also, from a HIS perspective, in the process of reviewing how we do our shared intelligence across HIS, again, just strengthening that HIS one team approach. And I know Debbie's going to speak. Debbie and Sonia from our data analyst team have been really, have joined our team and have been really helpful and positive in taking steps forward to gather some really useful workforce data to provide that further analysis and a development of a dashboard to host that workforce data. But that's a bit of a whistle-stop tour, and apologies because I appreciate how late we're all running. So thank you.
Thanks, Nancy. I think what I'll do is I'll move on to the next speakers, and then before we stop for breakouts, maybe do questions at that point for all of the afternoon speakers. So I'm going to now hand over, if that be okay, to Martin McKelvey, our Information Systems Consultant, and Debbie Redgate, our Systems and Analytics Programme Manager, for a kind of overview of our digitalisation roadmap for our tools. So thank you, guys. Over to you.
Thanks, Caroline. I think I'm starting. Thankfully, we need to get rid of that dodgy photo that's on the screen right now. So can we have the next? Thank you so much, Kim. So I'm going to start off by talking about the tools that we currently have and how they differ from one another before Martin comes in and talks a bit about the roadmap for digitalisation. So we have a set of acuity-based tools, and what they do is they calculate the care hours per patient day, and they convert that into a recommended full-time equivalent. In order to do that, the average patient numbers per day needs to be entered at that data entry point, and patient numbers per acuity are then averaged over the period of use, which is that 2-week period. That applies to our tools, which are adult inpatients, small wards, maternity for inpatients, neonates and SCAMPs. Next slide, please, Kim. Thank you. There's another set of acuity-based tools that we use, which uses the total number of patients per acuity per day. So that is the patient numbers that are entered into the tool are the total number per day, and those are averaged over the period and then provide a recommended full-time equivalent. That applies to the emergency care provision tool and maternity for triage, community and clinic. Next slide, please, Kim. Thank you. We also have intervention-based tools, and anybody who has been working with me on the 3Cs redevelopment will know all about this. And that is where we ask for the total number of interventions per day, direct and indirect. The average number of interventions per day then are calculated over the period, and the results provide that breakdown per activity category of activity. And that applies to our 3Cs tools, the clinical nurse specialist, community children and specialist nurses, and community nursing. Next slide, please, Kim. Thanks. We also do an activity-based tool currently on SSTS, which is a time task-based tool. And that tool looks at all the tasks completed per team per week and produces a recommended whole-time equivalent. That applies to our mental health and learning disabilities inpatients tool that we currently host on SSTS. Next slide, please, Kim. Thank you. So the tools that we have in development currently are mental health and learning disabilities inpatients and the maternity services tools, with hospital at home starting in Q4. These are being developed to slot into safe care, as has been described earlier on in this call today, and Martin will pick up now and tell us all about safe care. Thank you very much.
Thank you, Debbie, and I think we'll make a wee bit of time during this section, hopefully. Just to kind of follow on from what kind of Debbie said there, so it's just kind of setting the scene that we really have two types of tool. We have acuity-based tools and intervention-based tools. Our one activity-based tool, the mental health tool, is getting replaced by an acuity-based tool. So it's just to go over how these would operate in safe care. Obviously, we've touched upon this previously, that we will shift all of our current tools from SSTS over to safe care. And we touched upon the professional judgment that we are still assessing our options in relation to where we host that going forward over the kind of medium term and longer term. So a lot of you will have seen safe care already, but for any of our acuity-based tools, we are asking our users to enter patient acuity once per shift. So for most areas, that's probably twice a day. And you can see here that it's just a matter of entering how many patients they have at each patient level. And some of the tools will be supplemented by task types. Previously in SSTS, they would probably have been named additional tasks. So depending on the tool, that they may have task types or they may not. So it's as simple as that. So twice a day, enter your patients per acuity and any additional tasks relevant to that specialty. Next slide, Kim. Once you enter the patient acuity census data into safe care, you then are presented with this visual, and I guess it's just there as a quick sense check of the data that you have put in. There's lots of other data above this screenshot within safe care that may be relevant, but not so much for the staffing tool. We only need to know number of patients per level of acuity and the tasks. So that's just a screenshot just to show you what it looks like once you have entered the data. And just on the kind of top left there, you can see that there is, it says actual, and there is functionality within safe care that boards may switch on where you have predicted census periods, where it will take the last census period and say that that's now the same as this next one. For staffing level tool runs going forward, we would only base it on actual census period data. So that's just for noting that we won't do anything based on predicted. What we do is what Debbie kind of touched upon there, is if they've entered twice a day, we will then take the average patient numbers from those two census periods to create the average per day of number of patients. Next slide, please, Kim. So where we have an intervention team are based tools. So obviously our 3Cs have just gone through the work where we have created multipliers which are based on direct interventions or indirect interventions. I think for community nursing it's based on both. I think for some of them it might just be based on direct. But you can see here that you can enter as many interventions at different levels as is required. So for community nursing, we would be asking them to enter their total number of interventions per team per day. That might need to be done retrospectively. I'm not entirely sure of the finer details, but it works in the exact same way as it does for the acuity. It's just we have different levels of care, it's levels of intervention there. Thanks. And sorry, just the other wee one to call out in that last slide was for the 3Cs, certainly we have travel as an additional activity because of the variances across NHS Scotland, so they're not included within the multiplier, so they'll be recorded separately as a task. Next slide, Kim. Okay, so this is just a quick, some of the kind of key benefits of moving our tools to Safecare. I guess we're moving away from variations in how these tools have been designed within SSTS, so we're going to have a consistent method for all of our tools. And as you've seen there, it's very basic to use, so it should reduce on the kind of training requirements for users going forward. Where we have multipliers, they are interchangeable with real-time staffing assessments, particularly those that work over the average over a 24-hour period, which will create the care hours per patient day. So they will be there for your real-time staffing assessments, but also we will use the same data for staffing level tools. We have the option, I guess, that now, once we get to a place where Safecare is embedded, do we extend the date parameters for what is a tool run? Currently, one of the limitations of our tools is we ask it for it to be done over a 2-week period, minimally over a 2-week period once a year. We may want to extend those date parameters, given how kind of easy it is and how we want this to be built into business as usual. If you did record this on a daily basis within a profession, you could look out for an annual period, and then you might get seasonal variance shown within your outputs. Another benefit is we're able to deploy new tools or updates rapidly across NHS Scotland. So at the moment, most of you will be aware we need to go to Atos to make any changes, whereas within Safecare, we will be able to rapidly deploy any kind of changes to multipliers or tasks or anything that it is, and that will come at no additional costs. So there is no additional cost for hosting our tools within Safecare. We're using existing functionality, yeah, so that's a massive benefit to NHS Scotland, that we now own what we are doing and aren't relying on a supplier and their timelines for releases. As I've touched upon, it's very low data burden for staff, and particularly in comparison to some of our tools. And in terms of longevity, e-rostering is absolutely fundamental to a longer term business system strategy. So although I think the initial contract's for 7 years, the future roadmap is to build our corporate systems landscape around e-rostering, and that's why there's a lot of work going into that interface for e-rostering direct to payroll, so that it then enables us to move to a new software as a service payroll system in the future. So that system isn't going anywhere anytime soon, so we're safe in that perspective. Okay, next slide, Kim. So there's still a lot of work to get done before we can start to think about moving all of our tools across. I think Laurie touched upon the CR2 platform. That is our national reporting data warehouse. So you'll be aware that every board currently has their own instance of health roster Safecare. And there is work going on with RL Datex that will extract relevant data sets from each board's instance into the RL Datex data hub. And then that information will then be sent to CR2. And as an extra wee step in there, there'll also be stored on what we would call a Snowflake instance, which is basically will enable us to interrogate the data and produce Power BI dashboards to enable us to share outputs from staffing level tools with boards. At the moment, the timelines are unknown, but I guess there's been quite a lot of positive movement in that space over the last week or two. We met with the data engineers from NES who are starting to work on this. And I've went back to RL Datex after having a look at all the data tables that they're going to send to SEER, and there was a couple of fields missing that we would absolutely need. So we're into the kind of looking at the finer details of data fields and frequency of data getting sent from boards instances to the data hub and things like that. We've also got an IG lead at NES starting to look at the data sharing agreements and everything else around that, and that work should maybe take about 3 months before that's all bottomed out. So although I don't have timelines from NES, work is ongoing at present. We've touched upon our plans that our mental health and learning disability inpatient tool, once that's ready to be named in legislation, will be hosted direct in Safecare. Given we don't have the timelines for CR2 yet. We do have an interim solution should that not be available and operational by the time the legislation goes live, which is a macro-enabled Excel file. But hopefully we don't need to deploy that, and we have something operational for when that tool goes live next year. In terms of national reporting, there's a few stakeholders around that table. We've obviously got NHS Workforce, I guess Excellence in Care are looking at that as a data source as well. But nationally, we have agreed that the mental health and learning disability inpatient reporting is top priority for NHS Scotland. So that's where nationally we were focusing on in terms of prioritisation before we look at other kind of measures and other stakeholders and what they might want to report on nationally. Next slide, Kim. So the transition plan to safe care, we've been tasked by developing a plan Q4 this financial year, but there's a lot of factors that we need to consider when we do develop this plan. Touched upon it earlier that at the last programme board meeting for e-rostering, it was quoted that 27% had implemented Optima, so that's a rostering module. So we still have quite a long way to go before we see a kind of widespread implementation across all professions covered by staffing level tools. So that might mean that we are limited to what we can deploy and when we can deploy it. We need to take into consideration a number of areas included within each tool. Just an example, it might be far easier, it would be far easier for us to transition our emergency care tool. I think there's around 36 units across Scotland. If you compare that to our adult inpatient specialties, it's minimum, so that will have some bearing in to determine which tools we transfer across and when. Also need to bear in mind the tool development roadmap, so we've still to consider what tools we may refresh next financial year. There potentially wouldn't be a point in transferring a tool for us to then refresh that tool. We may take the opportunity to refresh the tool and then move it directly into SafeCare. And we've also, as part of the tool review recently, we'd sent out a user evaluation survey, and in particular we'd asked around the data burden for each specific tool. So again, if a tool was coming out to say that it was scoring high in data burden, then that might increase or would increase the prioritisation for when we transfer it from SSTS over into SafeCare. And again, we need to be aware of the CR2 timeline, so we can come up with this plan, but until we actually get our hands on the national reporting platform, it's difficult to put down exact dates. I think that might be my last slide, Kim. Okay, thank you.
Well, that was good timing. I have been kicked out about 3 times during that, so apologies, my Wi-Fi seems to be playing absolute havoc there. So thank you very much, Debbie and Martin. It is such an exciting and fast-paced development, and I'm always get my mind blown by talks of SEER and snowflakes. And
good afternoon. Thank you, Caroline. Great to be here. So yes, please, if we can move over to my presentation. Thank you very much. So in my short presentation, I'm going to provide with an overview of the emerging themes that were linked to the duties or are linked to the duties in relation to common staffing method. That came through the Q1 board reports that we already talked about, and the themes that came through the application of the multifaceted intelligence that Nancy had talked about in her presentation earlier on is our approach that we use when we monitor board's compliance with legislation. Can we move to the next slide, please, Kim? Thank you. So let's talk about the emerging themes in relation to board self-assurance, we can call it this way. Common staffing method is a duty specific to certain types of the healthcare provided at the locations and by the professionals listed in the legislation. There is a number of the boards that will be due to report on how they are discharging their duties in relation to common staffing method. So what data from the first board reports were telling us? So there has been 16 boards in total reporting on their progress through their internal quarterly report, and there has been one board that didn't submit a Q1 report, therefore we weren't able to use this as accounted in these matters. There has been 13 boards in total that had provided level assurance status against the duty to follow common staffing method, and 11 boards in total that provided the level of assurance status in relation to duty 12IL, which is a training and consultation of staff in relation to the use of the common staffing method. As you can see, there is an equal split for the boards reporting in green and reasonably assured to having their system and processes in place for application of common staffing method. The most of the boards also feel reasonably assured about their processes in place for duty 12IL. Can move to the next one, please. Thank you. So what are the emerging themes from quarterly reports? Boards are at the varying stages of implementation of the system and processes to support common staffing method. 2/3 of the boards are referring to have a substantial or reasonable assurance, if I've just talked about. However, we also noted the theme linked to identified gap, which refers to challenges around reporting and agreed governance processes for outcome decisions. Lack of clear and robust systems and processes in terms of ownership and accountability. In terms of education, boards reporting to have education support in place. This was referred to usage of staffing level tools, but also included education, awareness, support for application of all aspects of common staffing method. On the other hand, where boards identified challenge was often linked to staff engagement and capacity, and often gap in the provision of the adequate time to apply common staffing method or even undertake the appropriate training due to capacity pressures. We've seen lots of reference to locally developed resources, and they were supporting implementation in relation to education support, but also included resources capturing the process in form of standard operational procedures or having the frameworks developed, or resources that were supporting the reporting structures of the application and processes and outcomes of decisions. Boards reported to have a well-established staffing level tool runs in place which they adhere to. A theme that came through for a number of the boards was also linked to some technical challenges with access issues. And those were again linked to staffing level tools in relation to data entry access, and also access to the care dashboard to support common staffing application and using of all of the elements linked to the quality measurements. Staff engagement came in varying levels. When some reported the great staff engagement, others are already, as already mentioned, refer to their in their report this being a challenge. An effective communication to staff for that feedback provision were often recognised by boards to be an area for improvement. We have noted the theme around the board concern about the financial implications and limitations to support the outcome of common staffing method when demand significantly outweighs the capacity. So next slide, please. So our multifaceted intelligence-led approach gains data from a number of resources, as we've heard earlier on. From data intelligence available, we were able to recognise some emerging themes. We could see a disconnect between what boards are self-reporting and what can be seen via the data and the intelligence available. It came to the light that the boards have understanding around legislative requirements for utilisation of the common staffing method for designated groups. However, there are some gaps identified in that practical applications in terms of a robust governance process to come with the timely outcomes. Some identified gaps are being recognised by board themselves, however, not always clearly supported by identified mitigations or improvement and action plans being in place. in terms of the staffing level tools, data intelligence still acts the boards are using staffing level tools, but we can see that staffing level tools often are being completed with the data input errors or being incomplete. And what we can see is main focus on the tool's outputs rather than the focus on the outcome of the triangulation and using of the all elements of the methodology. In terms of that triangulation, application of all elements, as I said, specifically in terms how services specific real-time staffing data, that clinical advice and employees' comments are being used as part of the triangulation, and that long-term planning are often remains unclear. Services specific data and the safety, quality and safety data are often not included. And we also identified gaps in effective communication mechanisms for feedback provision of the outcome, which is a theme that have been identified by boards themselves very often. So I think that's it. That is finished with my summary overview. It was a very quick run through. So thank you for your attention.
Thank you very much, Michaela. Any questions for Michaela with regards to the common staffing method? And I'm looking forward to the hearing from the breakout rooms later in terms of how the application of it's going within the boards. But anything in the first instance? You can always tell when you're getting tired. The hands are not as quick as they were. Okay. Michaela, you've been let off lightly, so thank you very much indeed. And I'm going to move swiftly on then to our next speaker, which I think, if I'm correct, because I keep losing my slides, is Debbie, is that right? Brilliant.
Yep, me again.
She just waited and the slide came up. I did think it was you, but then I was like, couldn't remember the breakout was first. So thank you, Debbie. Over to yourself with regards to the dashboard.
Thank you so much. And thank you, Kim. So, as Nancy said earlier, in terms of monitoring compliance with the common staffing method, the analyst kind of team are going to develop a dashboard. We're kind of in the process of having a look at that right now. And we're going to develop that dashboard in Power BI, and we're going to be able to share that with the relevant stakeholders. We're not at the position yet to do that. It's in development. There's a lot of data wrangling to be done, and I'll explain all of that as we go on through this. However, we are looking for the first iteration of that to be available in Q4 with data primarily in the first instance from staffing level tools. Eventually, we're going to be including data that's accessible and relevant to that common staffing method where that exists and we're able to. Next slide, please, Kim. So in terms of the data sources that we'll be using, we're going to use in the first instance, the data from the staffing level tools. And what this does is, if you remember back to Michaela's slide there with that common staffing method triangle, that kind of meets that purple line at the bottom, the specialty specific staffing level tools. But what does that compliance look like? The things that we've got to look for in the data are things like correct application. Is it being used over the correct period in the correct way by the correct people? Are the rosters set up correctly when that sits on SSTS? Things like that. And the data quality issues that we're finding that we're having to deal with are things like if there are duplicates, how do we deal with that? And where is that missing data? What can we do with that? Do we need to be creating something then that pulls out all of that missing data and sends that message back to board and let you know that it's not being correctly applied, that tool. The other data sources we can use, obviously, there are professional judgment, and that ticks the professional judgment box of the common staffing method, and the quality tool, which does that whole measure of quality. So that's all on the bottom line there. That's your purple level, if you like, on that common staffing method. And that's just the data from the staffing level tools. Next slide, please, Kim. Thank you. Actual staffing we can get from the NES workforce published data. We're not in a position yet to include that in the dashboard, but the aspiration is that that will come. That also ticks the box, ticks the triangle, that final one on the bottom of the common staffing method about the actual staffing. Current funded can come from SSTS where it exists, but actual staffing can come from that NES workforce published data. And then finally, the other data source that we have or will have available to us will be from TURAS and SafeCare for that real-time staffing element, and that is that blue line, if you like, which includes the transparent risk-based prioritisation and decision making, and the other one is appropriate clinical professional advice. So you can see in here for the real-time staffing, although it comes from those two places, we've got severe and recurrent risks in there and escalations in clinical opinion. So that is, this dashboard will show the compliance with that common staffing method over all of these elements that tick all of these boxes, and that's your two lines, your purple and your blue lines, if you like, from that common staffing method triangle, all of which then goes up to that point, that is it pink or red at the top, that says that whether you are or not compliant. I think that is my last slide. Next slide. Oh, thank you so much, Kim.